Welcome back to the Chatty Vets Pod. I'm Brendan.
And I'm Charlotte. Thank you for tuning in.
And welcome to our third podcast of this month, our next 2 Week Takedown episode.
So this is where we aim to bring you up to date with all the latest news and products from the UK from the last few weeks.
We've got a busy show ahead, covering lots of topics from controversial neutering debates, and this is quite a big thing, and new evidence linking neutering to various health conditions. And I think we'll be changing how a lot of people give advice around this topic. And we've got another special guest on the show, so keep listening to hear a chat with the lovely Francisco to discuss all things ophthalmology relevant to general practice.
Yeah, it's going to be a good one. But one thing we wanted to mention before we get cracking, we have some very exciting news for you. This month, we're bringing you an additional bonus episode at the end of the month. So you've got 4 pods to listen to this month rather than the usual 3. Lucky you.
Yes, and next week, it's going to be a good one. You do not want to miss it. And we've got an amazing special guest on the show, and we're talking about all things regenerative medicine, platelet-rich plasma, stem cells. So it all sounds all a bit otherworldly and distant and remote, but it's here, and we're kind of blown away, but it feels like it's something we should all know about now. So more will be revealed on our socials this week, so keep your eyes peeled.
I'm actually so excited for next week. We recorded the episode a while ago now, didn't we? And we've been dying to get it out. We absolutely loved the interview we had, so we know you're going to love the episode just as much as we enjoyed recording it. We can't wait. But anyway, back to today's pod. Hopefully still just as interesting for you.
Yeah, but before we get stuck into some of the big topics in this episode, let's have a little chat about a few discussions we've been having with listeners recently. So Marcus on WhatsApp had a brilliant message. The first one was about something called PrimVet. Have you heard of this, Charlotte?
No, never. No.
Right. I hadn't either. So he told me about it, and it's really good. So it's basically someone, you know how obviously nowadays we're looking things up on AI, but they've created an AI called PrimVet that's really targeted at veterinary resources. So it's using, a lot of veterinary publications and literature and all of this stuff. So when you do something, it shows you all the evidence, but so you can ask questions. It gives you really kind of referenced answers. It's feeling pretty good.
Okay, cool.
Yeah,
and you just
free.
access it on Google or whatever. You just type it in and you can find it.
I've got an app on my phone. I think it says PrimVet. I say, yeah, there's no charge. Yeah. And I noticed on LinkedIn, they said they've got 5,000 users in the US and UK. So yeah, I think it's early days. So that was number one. Yeah. And then, so Marcus raised some really good points about opioids and nausea, which I think is worth knowing because it will affect your clinical practice. So the first thing to say is that opioids cause vomiting through the CTZ, the vomiting center, which sits outside the blood-brain barrier and gets hit quickly. But something I didn't know is that there's also an anti-nausea opioid receptors, which are inside the brain. Yes. So the relevance is now certain drugs like morphine and hydromorphone, they're less lipophilic and they actually hit the CTZ, the chemoreceptor trigger zone first and cause vomiting quickly. But the more lipophilic opioids, they cross into the brain quicker. So then, yes, they hit the kind of nausea-inducing CTZ vomiting area, but because they go into the brain really quickly, they then hit that anti-nausea effect and they actually don't cause as much vomiting. So these more lipophilic opioids are methadone, fentanyl, buprenorphine. So that explains why there's this little difference between the two.
I wonder if there's any difference as well between, like, if you give it IV versus IM and the speed that it acts, and whether there'd be any difference in nausea because of that too. Like whether, because it's going to take, do you know what I mean? Like whether
Very
that then
clever.
affects how the time between it hits the CTZ and then crosses the blood-brain barrier, whether that makes any difference too, or whether it's just it happens at the same speed, but it just takes a little bit longer for it to get there. I don't know. So
yeah.
Who knows? But yeah, that's really interesting.
Yeah. And the other thing which leads on from it, the clinical, really big clinical relevance, is the next dose would be less nausea-inducing because now the drug's hitting that anti-nausea in the brain. So you've already got that going on, because I think I'm really concentrating when I give my first dose, but I'm not concentrating 3-4 doses down the line. And I think you really notice the nausea. But now I think back, yeah, that's true. You don't get as much nausea. And this is something, I'm so pleased this came on the comments because I've always wondered about it. So Almudena Gonzalez Gilbert lives in southern Spain. And they've noticed that dogs eat grapes straight from the vine in that area, and they're not seeing renal disease all over the place. And I just think it highlights how infrequent the toxicities are when, someone there, surrounded by grapes literally growing everywhere. Yeah.
Yeah, and we've actually had a couple of comments from people like Shauna and Mel on, I think it was on Facebook, wasn't it, as well, sort of in the comments feed, to say about how, again, they've had experiences where they've not really had that much incidence of toxicity as well. And don't get us wrong, that's not us to say that we don't need to be worried about it, because they definitely are linked to an AKI, but it just proves, doesn't it, like the evidence is constantly changing. And I think maybe it's not quite as scary as we initially all thought it was. But that doesn't mean we should be 100% changing what we're saying to clients. But I think it just means we need to spark more research into it to say, okay, how nervous do we have to be?
Now, Shauna, I know you're going to be like, hold on, I didn't say that. So let me just, but Shauna she said that it's slightly on the other side of the spectrum. Her dog, she had a golden, ate half a loaf of Irish soda bread with raisins, and then they got the dog to vomit up 22 raisins. They did diuresis for 48 hours. Now, yeah, like in some ways you kind of go, well, the renal values stayed normal, but what she did notice was 4 days later there were granular casts in the urine which show kidney injury. You've got that. So there was something a bit more nuanced, that one. So there was evidence.
But then I would kind of ask as well, if it's been diuresed for 2 days and potentially been over perfused for 2 days, potentially, then how much of the renal injury has come from the fluids and how much has come from the grapes or raisins? That's what I'd ask. Can you get casts
that's what you can ask, but it's not very delicate, is it? To Shauna's feelings.
No, I don't mean she's wrong at all. And I'm saying that she's right. It indicates kidney injury, but I'm just saying it's interesting to think that why has the kidney injury happened? Yeah, exactly.
Do 2 days? Yeah, go on.
Yeah, do you see what I mean? Because most people stick them on 2 or 3 times maintenance when they're already normovolemic. So we're massively over perfusing them. We're probably giving renal edema. Like, how much of the injury is from the fluids versus how much is from the raisins? Like, we'll never know, from that case anyway, because you can't go back in time and check. But it's just really interesting.
Pet Savers, another one. Control study. Dogs that don't have diuresis, look at the urine for urine casts 3-4 days later. Do the ones on diuresis have evidence of renal harm?
Yeah,
I think there is some evidence. Actually.
Yeah, because would you get casts just from overperfusion?
Well, yeah, that's a good point. Actually,
I don't know.
We need
what
a renal
specialist.
Yeah, that's the next one. If you're a renal specialist, yeah, come on, message in, and we'll have you on. That would be brilliant, wouldn't it? Actually,
yeah. Yeah,
okay,
make us sound like we actually know what we're talking about.
Yeah.
And I guess while we're here as well, it would be worth bringing up. So I know Kelly messaged in on socials to say, do we actually have any studies, because we've been saying for a while now, we generally don't really promote the use of IV fluids after a raisin or grape ingestion now. And do we have any actual studies that say why we're doing that? To be completely honest with you, no. And that's the real issue with the topic at the moment, is that there's no evidence to say that it's right or wrong. But I think it's being extrapolated from a lot of human medicine and human research, where they're finding things like increased fluid therapy can contribute to an actually worsening outcome in patients with AKI, potentially, like overperfusion. We know that it can cause renal edema in patients. And actually, Brendan, you said something about there's a study where potentially like increased fluids for a few hours even can reduce GFR. So I think there's definitely the evidence there. But specifically for raisin or grape ingestion and IV fluids, the evidence just isn't there at the moment. So that's why we just need to be super careful with the way we're talking to our clients, because we're saying, look, the evidence looks like it's trending in this direction, but ultimately the pet poisons, etc., are still recommending fluids because there's no absolute evidence to say that this is what we should be doing now. But anyway.
And we had another one, by the way, which was Josh Stone, about how we talk about complications from surgeries and complaints, which is a slightly kind of like distressing one for me and you to have to talk about, but it's a goodie, isn't it?
Yeah, and I've got some very good stories probably that we could talk about.
Too.
So yeah. I think we probably all do. But yeah, no, I think that'd be a really cool topic. So I think we'll definitely build that into a 2 week takedown coming up soon. So thank you, Josh. That'd be great. Okay, right. Moving on to our big topic for today. So, something else we do every day, but that seems to be changing a lot as time moves on, when or if we are recommending neutering in dogs. So I feel like even what I'm recommending now has even changed a little bit since I qualified. I mean, I only qualified in 2021. So I think things are really moving, seem to be really changing. But what about you, Brendan? Do you think they are?
I'm going to sound like such a know-it-all now because I have been telling people what I was taught in the 90s in Bristol University. So credit to the people who taught us because they were obviously, I don't know, up there. I am honestly genuinely puzzled how I'm just doing what I was taught 30 years ago. So yeah, but the evidence is definitely building for sure. I think deep down we've all kind of known this, haven't we, all the time, that especially large breed animals should be delayed neutering, that it's better to let bitches have 1 or 2 seasons before we neuter them if we can, and that once they're starting to get to several seasons, then that mammary cancer risk is starting to come. Is that a kind of neat summary of where you're at,
Yeah,
or have I missed a
I
bit?
think I think we'll probably get into it a little bit more, but I think the big change is that it's not a one size fits all recommendation anymore. I think traditionally it was always neuter them at 6 months old, everything gets neutered, male or female, get everything out, no pregnancies, no pyos, perfect. But I think it's definitely more of a discussion about breed, discussion about behavior, discussion about what they want to use that dog for. You know, there's so many other things that come into play now, even IVDD and DAXIs. Like, there's so many different things that we're talking about now. And I think that we're now knowing that, especially in our medium to large breed dogs, that if they're neutered early before skeletal maturity, there's definitely a clearer relationship between that and orthopedic disease. So cruciate disease, hip dysplasia, elbow dysplasia. It's a bit less obvious in your small breed dogs, but if we end up neutering early, there can definitely be some sort of issues that are definitely coming out in the literature now. So we know that there's definitely a link between cranial cruciate ligament disease. So there are various studies that have come out that said that neutered male and female dogs have had a significantly increased risk of cranial cruciate ligament disease compared to intact male and female dogs. And apparently those studies also show that the risk of CCL disease in those dogs was greatest with the dogs that had had the least gonadal hormone exposure. So basically the ones that had been neutered earlier rather than later are more at risk of developing that disease. And, you know, we see cruciates all the blooming time, don't we? So that's really worth knowing, especially in those larger breed dogs that you know it's probably likely going to happen at some point. So that's a massive chat to have with people. But maybe before we dive into some more of the issues that we're noticing with early neutering, maybe the big discussion we need to have first is, should we really be neutering our male dogs at all? Is everybody still recommending, or are there people still blanket recommending castration? I hope not, but maybe there might still be people out there that are. But there's definite links to other issues.
I think this is something that we've got wrong for so long. Yes, well, from the year 2000, I've been recommending that it's not a health benefit to castrate male dogs, but that's nevertheless, it's sometimes good to castrate male dogs because of the context. You know, if they're humping everything in sight, it's getting in the way of their interactions with other dogs, or they're humping guests and it's getting in the way of things like that. It's usually the small fluffy things, aren't it? They're like crazy humpers. So there's reasons to castrate a male dog, don't get me wrong, but we need to be getting away from the idea that this is brilliant for their health. And the way that I've always brought this up is I've said, look, when they're not castrated, there are a few things that they can get, usually beyond the age of 4 or 5 years of age: prostate infection, the anal adenomas, the perineal hernias, the testicular tumors. But we've got increasing evidence now of all these joint and cancer problems by neutering them early, and we've got to get the balance right and have a more nuanced discussion. Yeah, is
Yeah,
that kind of
exactly.
fit with you?
And I always say to people, so I phrase it like, for me, it's very 50-50 in terms of health concerns, because yes, if they're entire, there is things that they're more likely to get, or they can only get if they're entire, like testicular cancer, which we know isn't that common, but it can happen. BPH, really common in entire male dogs. But the majority of those sort of things can be fixed with castration at the time if you need to. So if it's a problem, you castrate them. But we now know that there's also a link to diseases by neutering them. So like the general discussion we're going to have with cancer, etc., but also specifically to male dogs, prostate cancer, so prostatic neoplasia, has actually been linked to be potentially be more likely in dogs that are actually neutered. So BPH is definitely more common in your entire male dogs, but prostatic neoplasia is more common in your neutered dogs. And obviously that's not something we can very easily fix. So I do have that discussion with owners.
And that evidence has been there for decades, by the way.
Exactly.
And
Yeah.
how many times will I have, I'll hear staff saying the opposite. So I think it's something we need to get right. Yeah,
Yeah,
it's been
definitely.
well known for a long time.
Exactly. And I think we all need to be having that behavioral discussion as well. Because right, we all know that testosterone increases confidence. You neuter them. And if you've got any level of anxiety, nervousness, etc., especially in our dogs post lockdown, who are all tend to be a little bit that way inclined, you castrate them. And how many dogs have we all seen that have gone nutty and really difficult to handle after they've been castrated? Because then nervousness and anxiety goes through the roof. So it's, yes, don't get me wrong. And I always say that's very dog dependent. You can never guarantee exactly what's going to happen. For I tend to try and discuss with clients if they're absolutely desperate to neuter. Tend to try and discuss chemical castration before surgical for that reason, because if they become a dog that they don't really like, well, maybe that's a bit too strong a word, but if their behavior becomes tricky to handle and they think, actually, I don't really like this, they've become a different dog, at least it's temporary. You put the 6-month implant in and you can go backwards. Whereas if you chop their balls off, no going back from there. So I think, like you say, it just needs to be more of a discussion. And for the ones that they're desperate to neuter one of their dogs, if they've got a male and a female in the household, I would be suggesting to neuter the bitch rather than the dog. But everyone's different. But I think, again, it's having those contextualized discussions based on the patient and the client. So
Yeah, do you know what? Having given this advice for so long, what I tend to find is people will come back with their boy dog, and the dog will be about, I don't know, somewhere between 3 and 5 years of age, and they'll go, "My dog is wonderful, perfect behavior, everything's great, but I want to get him neutered because other dogs are starting to fight with him or wanting to fight with him, or he's getting more interest from other male dogs in a negative way." So, but that's fine too, because now you've had that extra, the skeletal maturity, we've got better
mm,
body conformation, and we've got better health outcomes, hopefully. So, yeah, just be aware of that. Add a couple of nuances. I don't know if you found this, Charlotte, but I found unneutered females in the same household can be a bit more likely to fight. Normally, it's a delay, I find. It's kind of 2, 3 years old, 2 to 4 years old, that kind of age, where that secondary kind of characteristics are coming through. They're getting more assertive. Yeah, so they're
yeah,
the
yeah.
kind, but there's so many nuances to this that it's suddenly really hard to kind of guide people through the conversation.
Yeah. I think it's basically just to say that it's not a blanket, you must do this, and it's not a blanket, definitely don't do this. It's a discussion. And that's the whole point, isn't it? There's pros and there's cons against it. And for some dogs, it will absolutely be the right decision. For some, it will absolutely not be the right decision. So it's just having that chat and form your opinion and just chat to your owners about it. But I would say don't have a blanket protocol because it doesn't work.
Yeah, let's get into the cancer stuff, because there's lots of good
Yeah.
newer evidence, and the cancer stuff was quite
Mhm.
amazing because I think this was mainly golden retrievers that had increased lymphoma, hemangiosarcoma, mast cell tumors when they were neutered, and Rotties getting more osteosarcs when they were neutered, and that's
Yeah,
kind of
definitely.
scary because I think we all see these types of cases.
Yeah, there was an osteosarc study with Rotties, which said that I think it was something like osteosarc develops in approximately 25% of dogs that are neutered prior to 1 year of age. So, like a massive percentage. And this was statistically greater than intact counterparts. So there is definitely a link there. And we all know in those big, large breed dogs, if they get an osteosarc, even if it's not spread by the time you diagnose it, a big, hefty rotty, not the ideal candidate for an amputation. If we can try and avoid that at all costs, then great. Same with lymphoma. There's definitely studies out there that say that there's an association of neurostasis with developing lymphoma. And I think you're right. That study was really in golden retrievers. So and I think they said something like neutered males in particular develop lymphoma 3 times more often than intact males. So a big difference. So there will be more and more data coming, but there is 100% links there. Sex hormones have so much of a bigger part to play in terms of long-term health development, skeletal muscle maturity, etc., than we ever previously realized. So it's definitely more of a conversation to have with owners now. And I think the thinking on mammary tumors has changed a bit from what was traditionally always said. Do you not think?
Yeah, because I think there used to always be that evidence from that 1960s study, and that was the only study we had. But that one, I think, once they were having 3 or 4 seasons onwards, they were starting to see some mammary tumors later in life.
I think it's basically if you neuter before first season, then it gives you a massively reduced risk of mammary neoplasia, especially in your small breeds. The risk increases with every season that happens. But basically, if you spay after the second season, the data was something like that it would then no longer reduce the risk of mammary neoplasia. I think the thing is that paper has been shown to be a little bit weak in terms of its evidence. And I think there are now some studies that there's like a systematic review that came out, I think it was in 2025. And it said that they found that there was no real evidence of a protective effect of early spaying against mammary tumours in dogs. How much does it come into play? I don't know. And
How often do you see a mammary tumor in a dog that's neutered early? I mean, I've not. I've not had it. We can't say that early neutering doesn't have a protective effect on mammary tumors, because also I've seen a million mammary tumors because doing PDSA work, loads of unneutered females. We'd get one every week at when I was in Oldbury, a busy PDSA clinic in the Midlands. We'd one a week, I remember thinking. But when you're in private practice where they're all being neutered, one a year, and it will be
but I think
unneutered.
what I'm trying to say is I think there is that link between hormone development, hormones and mammary neoplasia development. But is there a link between neutering early as a protective effect or just neutering in general? That's what I'm trying to say.
So there's not an
So that
additional benefit from
Yeah,
early neutering.
maybe.
I
So
get what you're
so is
saying
it
now.
so I think the initial study that everyone used and quoted was basically saying that the earlier the neutering, the lower the risk of developing mammary cancer. But I think the evidence for that is fairly weak. So I think we now need I don't maybe if there is one out there, then someone tell us, but I'm not aware of one. It would be ideal to have one that if they're neutered at the appropriate time in terms of for all the other risks, once they're skeletally mature, larger breed dogs 18 months to 2 years plus, smaller breed dogs at least a year, 18 months maybe. If we neuter at that point, is there still a protective effect against mammary cancer? So I think you can still say there is risk between not neutering them and developing mammary cancer. We know that that is likely, but it's still not 100% certain in terms of when we should be neutering and the risk of mammary cancer. So that's maybe where I think that the field is a little bit more open still.
This leads us nicely onto this ovary-sparing bitch spays. Because have you heard, this has just cropped up in my world. Well, one of my friends worked at a clinic in Wales and they were doing this ovary-sparing bitch spays. Now, I'm not saying this is a great idea, but I can see now I'm starting to understand where the rationale comes from, having had this chat about the link between early neutering and cancers and joint disease. So I think what some people are doing is they're taking out one ovary and the womb. Now, obviously, you've still got some mammary cancer risk, but I think they're implying on the upside, you've got healthier joints, and you've got less cancer risks for other cancers. And maybe I'm inferring this because I'm not being able to read about all this. Maybe they're saying, well, if you do get a mammary mass, you're on the spot, look out for it, deal with it early, because I find usually it's the ones that are left for too long, and I do think they actively turn more and more cancerous over time. I might be a little bit wrong with that, but that's my experience of it. So maybe they're thinking, keep an eye on the mammary tumors and you get all the upside. It's starting to kind of, at first when I heard about it, I thought, God, that's complete trash. But at least now I can kind of see where they're coming from.
But then I kind of think, well, why bother neutering them in the first place? Because you still have the risk of stump pyos and stuff.
But
I don't
stump
know.
pyos are easy to treat, aren't they? You just that bit of antibiotic and they're done, aren't they?
I still think like they're still going to have the hormonal change. Yeah, they might not be bleeding everywhere, but they're still going to act differently. You're still going to have false pregnancies, like all of the other things.
They're not going to bleed everywhere, though, are they? Or they're not much.
No. That's what I said. Yeah, so they're not going to bleed, but otherwise they're still going to go through all the normal hormonal change. You're still going to get male dogs that are going crazy whenever they're in season. So
yep.
I don't know. I sort of just feel like what's the point? Like either
the
neuter or don't.
All the things you just talked about, isn't it?
Yeah, but
to play devil's advocate.
I just sort of feel like why put something through a massive abdominal surgery for like a halfway house? It doesn't really make sense. I don't know. Personally, I feel like that doesn't really make sense. I feel like you take it all or you don't take anything. But I don't know. Maybe I'm wrong.
Because it
seems a bit odd to me.
Yeah, I think you know what? I just think we need more understanding and knowledge about this because the cancer risks with neutering, they're patchy, aren't they? We've got the golden retriever thing. But then retrievers are a little bit prone to cancer, so they might not be typical. I think there was something on Vizslas as well with lymphoma and other cancers too.
And
In terms
Rotties
of
get
some
all sorts of
evidence.
weird stuff, don't they? I mean,
Yeah.
I think a lot of the really weird cases I've seen in my
Yeah.
career have been Rotties.
Yeah.
So they get all sorts of
Yeah.
strange things, yeah.
But then maybe we're seeing that signal in those breeds because the signal's kind of louder. So it's easier to spot it in a smaller study. But maybe we're getting just the same thing in others, but it's harder to spot because they're less frequently affected.
Yeah.
I think it kind of opens my mind a little bit. I'm not completely ridiculing the idea now that,
No.
you know, we've gone over all of that. You can see where, I think it's really important to see where people are coming from. So,
Yeah.
you know,
Yeah,
and I
yeah.
think I can see where they're coming from now with why
Yeah.
you do
I can
it.
I can see the principle behind it. I just think I'm not sure I don't know. I don't think I'd be wanting to be recommending a massive abdominal surgery because it is a big abdominal surgery, isn't it? I mean, even lapse phase, it's still a big surgery and there's a lot of stuff that can go wrong for like a halfway house. It just feels weird to me. I
Yeah.
think, again, it would be really nice to have some studies that say ovary-sparing technique, is it better than leaving them entire or taking the whole thing? What are the pros and cons, etc. But we just don't have that data, do we? So, which is crazy because we're something we do in vet med all the time and we still don't have loads and loads of evidence in terms of what's the best thing to do. So, yeah. And I think it'd be interesting, anyone who's in America to chat in as well, because I think ovary-sparing spays are more common in America, I feel like. So yeah, anyone who's in America and is doing them really routinely, let us know, because if you find that there is pros or cons or whatever, then let us know why it's being done quite so much. But yeah, there we go. And I guess one of the other controversies to talk about at the moment.
Oh, can I just say quickly on that ovary-sparing thing? We have a real problem with female entire and female neuter, don't we? All of our sex gender things need to have a third category. Anyway,
God,
I just thought.
What do you say?
Yeah.
Like female half entire? Like, what do you call it?
Yeah. Self-declared. Yeah, just number of ovaries. That'll be what it'll be. Maybe. Yeah. And womb.
And one of the other controversies to talk about at the moment is the potential link in DAXIs between neutering and IVDD. So there's been some studies in the last few years that suggest that neutering, especially if performed before about 12 months old, increases the risks of IVDH in DAXIs. So, I mean, I think, again, and there was another one, I think, in 2024 that actually found that there was no significant difference between early neutered, late neutered, and entire female DAXIs. So, I don't know. I think that, again, is the evidence where it needs to be with that for us to be able to say, don't do it or do it, or when to do it, maybe not. But I think there's enough to say there is a potential link there. But then, is it just because we see IVDD and DAXIs so much that we can potentially form a link in a smaller study? I don't know. I think that, again, we need to have some more evidence out there to give us a proper push in either direction.
Charlotte, there's one answer to this question. Early neuter every dachshund until there aren't any more dachshunds left, because then you won't have any IVDD, because
you're going to get some people hating you when they've got DAXIs, yeah.
But yeah, I mean, I own two. Well, I did. My wife had two Basset hounds, so when I met her, so we had those two. But yeah,
it's tricky, isn't it?
Even worse.
Yeah, but I mean, I've seen it in. I mean, I'd say probably the same as everybody else, but I've seen it in intact females, intact males. I've seen it in neutered females. I've seen it in neutered males. Watch this space for maybe more evidence is going to come out. And again, I wouldn't be making a blanket decision as to whether to neuter or not to neuter, or when to neuter, based on just the evidence out there at the moment. But I think we need a bit more coming out to let us know, definitely. But yeah, it's just something to consider. And then I guess on that, you've also got things like increased weight gain when they're neutered. We've all seen that they all get a bit chunky. So I think it's now sort of more normal practice to be saying to people, maybe cut their food down a little bit, or try and get them as lean as you can before surgery, because you know that they're going to try and put on a bit of weight afterwards. We know that there's potentially a link between increased phobic behavioural disorders and neutering potentially. But the one big thing that we've not spoken about, USMI, so urethral sphincter mechanism incompetence in large breed dogs. So there was that study that came out with the RVC, wasn't there? And neutering in early onset urinary incontinence in UK bitches, wasn't there, that they brought out?
2019 study. So this is basically the big thing is, well, I think we kind of know neutering increases the risk of urinary incontinence. I mean, they're saying early onset urinary incontinence. That's significant, I suppose. But also that if you go less than 6 months, it's another risk factor for getting urinary incontinence. So it's kind of that timing again. And that was particularly relevant to several breeds, wasn't it? Irish Setters,
Yeah.
Dalmatians,
Yeah.
Vizslas, Dobermans,
Vizslas, yeah.
Weimaraner's, Springer Spaniel. Yeah, well, no, I don't know. It's probably other breeds too, isn't it? But they came up. But yeah,
Yeah.
that's quite a
Yeah.
big thing.
Yeah, definitely. And they brought us some big figures like there's an increased risk of early onset urinary incontinence in neutered bitches compared with entire bitches, and that's twice as likely. And then it's 1.82 times as likely or increased risk of early onset urinary incontinence in bitches neutered before 6 months of age compared to ones that are neutered between 6 and 12 months of age. So I think there's definitely a link there. So it's basically saying that if we neuter them early, so 6 months or earlier, they're more likely to develop urinary incontinence in general and to get it earlier in their life than they would do otherwise. And, that's a big thing for owners. Like, how many people have you had come in saying that they're ready to euthanize their animal because they're weeing all over the house? Like, it's a massive thing for people to have to deal with. And they also, another thing to help with our battle against weight in dogs is increasing body weight has an increased risk of early onset urinary incontinence. So if you can say to people, get your dog to lose weight, otherwise it might piss all over your house, might be really helpful. So yeah, it's a good thing to chat about. But yeah, have a little look at the study. I think it was by Grimm et al. In 2019. There's quite a lot of information out there about it, but basically sort of the long story short is that in your large breeds, just don't neuter them early if you can help it. Try to get them to sort of at least 18 months of age or so. Let them skeletally mature. You're going to reduce the risk of urinary incontinence, these sort of horrible bony issues that we can get, elbow, hips, cranial cruciate ligament issues like osteosarx, lymphoma. I think the evidence is definitely pointing towards neutering those guys late for sure.
Can we say because we had this little thing on socials with the American, particularly American, maybe North American vets kind of really being shocked that in the UK the vast majority of vets inject into the scruffing cats. So, but the other side of that is in America, I think really early neutering is so standard, I believe, where they're neutering at 3-4 months of age, at least on my vet groups. So correct me if I'm wrong, but I'm hearing very early neutering. And in the UK, it's not a common thing. I think there are more non-UK kind of graduated vets that maybe are doing even earlier neutering, but historically it was always 6 months and onwards.
Yeah.
But that you see this is the nuance of everything, isn't it? This might have a bigger health issue than certainly in the UK population than injecting scruff versus leg.
Yeah, exactly. And I think if you are in America or overseas and listening and you do routinely neuter really early, for example, then please do let us know, because I know that we thought people would find it not very interesting listening about vaccinations, but honest to God, it went crazy on social media. So I got battered. But yes, it's really interesting. And we love hearing the debates and the different points of view and exactly what people are doing in different countries and why. Please let us know if you completely disagree with everything we've just said, if you think that you really agree and you've got more evidence that you want to share. Absolutely, please spark a debate with us, because we really enjoy it. We love the clinical discussions. What I think we should do, Brendan, is maybe we do a blog post that we release with this podcast so that we can get everybody discussing. So if you don't know about it, we're running a blog. You can reach it through our website. The link is on our socials channels, and I'll put a link in the podcast show notes from today as well. So please, if you're interested in getting involved in the discussion, have a little look at that blog and drop us a comment, because it would be really, really cool to spark a discussion about what everyone's doing in practice now. So yeah, please do get in touch. Leaving neutering controversies and things behind, we've specifically not talked about cats and rabbits in this episode because we knew there would be a whole lot more chat about them. So we'll cover that in a later episode. Just before we move on to our chat with Francisco, which hopefully you guys will really enjoy, we wanted to have a little bit of a chat about euthanasias. Now, I know we've touched on it on previous episodes in terms of how to have the discussions with owners, how to do the consult, maybe drugs that we might want to use beforehand. But one of the difficult things that we find is when to have the discussion about payment, because it's bloody horrible, isn't it, talking to people about that?
Yeah, this came up because one clinic I worked at, which was actually quite an affluent client base, and they started to insist that payment was done at the time of euthanasia, not later. And I think practices really vary on their protocol here. I think it depends on your client base. I personally don't think it's a good look if you're kind of rustling people to the counter to pay after you've euthanized them. I think it would probably be better to say a lot of people just want to get it done. So I'll tend to phrase it, look, some people just want to just get straight out here. If you like, just get the payment done right now, or, but normally I'll be saying, look, if it's afterwards and you've missed the opportunity to talk about it, I personally don't, unless you've got really bad client debt or different client population. Most of the time, I'd rather just say, look, don't feel, just pay when you're ready. That really is the least important thing right now. Just take care of yourself. But am I being too ideal world and woolly? Probably.
I don't know. I think I always used to do that in general practice. Like I used to be like, sometimes I'd let them out the back door or the side door so they're not going through the waiting room as well because if they're all crying. And it's horrible, isn't it, when you're feeling that crap about something that's just happened and then you've got to stand at the counter in front of everybody and bloody make a payment. It's not ideal, is it? But then I think now I'm doing ECC work. The tricky thing is people have to pay because they're not regular clients. So you're seeing people from anywhere that might have any sort of financial background. You have no trust built up with them and no sort of client relationship that like those practices do make you pay before you leave. So I think I've now sort of got into the habit of talking about it anyway. So now whenever I do GP work, because I still locum, I do tend to just have the discussion with them then and say, I'm really sorry, but if I know horrible discussion to have right now, but if it's okay with you, if you can either pop to the counter or I can ask one of the reception team to come in here and to take a payment from you now before you go, and then it's just out of the way. And the majority of people are like, yeah, no problem at all. I tend to find the people that argue with you are the ones that are probably not going to pay the bill anyway, in which case, if they get funny about it and they've asked for an individual cremation, I just say, that's absolutely fine. If you want to take some time, that's no problem. But just to let you know, we'll have to hold your little love here and keep them comfortable until you have paid the bill, because we can't send them for an individual cremation until the bill is settled. And I say it in a really nice way, but I think it gives you that incentive because they know that they have to pay it. Otherwise, they're not going to get the dog back or their cat back. So I don't know. I think it's that fine line, isn't it, between being really nice to someone and trying to help them out in a time where it's really crap for them versus being a bit too nice and forgetting that we are a business and they still have to pay. It's tricky, isn't it? And I think, like you get welfare euthanasias come into it. And yes, if people have no money and it's dying in front of you, then fine, that's a different story, isn't it? But I think ultimately people know that they have to pay for euthanasia. And the majority of the time they're quoted a price over the phone before they even get to you. So they know what they're getting themselves in for.
The issue isn't the euthanasia, it's the body, isn't it? Because especially in out-of-hours practice, if you don't handle this right, you've got 5, 6, 7 bodies in the freezer. And sometimes you can't even get hold of the client to decide, is it individual, is it communal? Because if they haven't paid and they've stipulated or they've said we don't know at the time and they've not got back to you, it's a real management headache. So I think in general practice it's less of an issue, but it still can be if you've got a really big body. And it's a big hit to the practice to pay for the cremation.
The only other thing I wanted to bring up here, which I've had a couple of people ask me and I've never known how to respond. Have you ever had it where someone's gone, you're not going to put them in a bag, are you? Because I think people don't really think about what happens to the bodies, but sometimes they are aware that what might happen is they might get put in a bag and put in a freezer, which is obviously what happens to all of them. But people don't like to think about that. So I've had some people say to me before, oh, you're not going to put them in a bag, are you? And I'm like, well, CPC aren't connecting for like 4 days. So I'm not going to leave it out on top of the freezer. So, but then what do you say? You can't be like, no, sorry, it's going in a bag and in the freezer. But then you can't lie. So I normally just say, don't worry, we'll keep them nice and comfortable. Because what are you supposed to say?
So I say something like, keep them on their blanket for as long as possible. But eventually, we do have to freeze them. So that's how I kind of phrase it. So, but don't worry, won't
That's good. Okay.
That's my kind of get out of.
Yeah. It's horrible, isn't it? Because you don't want to tell people, they go in the freezer in a bag. But then, like, we can't lie, can we? It's horrible. But
yeah, but then I'll go out back and I'll say, just keep this one on the bed for as long as you can. And the staff will look at me and I'll go, just because we said, and then it could be 5 minutes, it could be an hour. I don't know how long it's going to be. But we do the best we can to try and... I think this came up with another conversation with a vet I was having where sometimes we have to follow certain rules. But I think as long as you can come across like you're listening and hearing what they're saying and you're trying your best, even if your best is they're going to be on the bed for 7 minutes, I think that gets you somewhere with the client, doesn't it? 'Cause it's not then this rules thing. No, they have to go straight in the free. We can kind of bend a little bit and still follow the rule. And I think we might gain a bit more affection from our clients.
Yeah, I don't know. It's a tricky conversation to have anyway.
Yeah.
Okay, right. Let's get to the exciting bit. We recently interviewed Francisco Gomez, an ophthalmology cert holder who runs a mobile ophthalmology service going between different clinics in both Spain and in the UK. So here's what he had to say. So, welcome, Francisco, to the podcast. Thank you very much for coming on board.
Hello.
Hello.
Thank you for having me.
Yeah, no worries. So, for people that don't know who you are, do you just want to start off with a little bit of an introduction about yourself, like where
Yes.
you live, where you work, what you do, etc.?
Okay. So my name is Francisco, and most people call me Fran. I am a advanced practitioner in veterinary ophthalmology. I have worked in the UK. I started to work in the UK in 2007 in first opinion practice, and eventually I became the clinical director of a practice in Nottinghamshire. After that, COVID came, and that time I was trying to, improve my ophthalmology. Ophthalmology is something that I've been doing for quite a while, try to get better at it. And I did my certificate, I became an advanced practitioner, and then I got a job in a referral center for a couple of years. I think the benefit is that I have had a lot of contact with first opinion, and then I have worked also in a place where I only do ophthalmology, so I can find the line in between. Often something that I see is the referral world is a world that's miles apart from first opinion, and that's where advanced practitioners should come in. So, and I think I can help with that. So right now I moved to back to Spain, where I am originally from. I'm from Costa del Sol, even though people don't see it, but because I am of pale skin, the rest of my family aren't. And then people used to ask me, your accent is not British. Are you Russian? I'm not Russian. So now I work in both the UK and Spain. In Spain, I have my own business. It's called Ojo Veterinario, which means veterinary eye. And what I do is I see referral in practice. So I go to practices, people who know me call me when they have an eye problem, they book me an appointment, and I go and see the patient as a referral in-house. And because I can do that as well, we don't have the 24/7 requirement from the RCBS in Spain. Therefore, I can actually take a weekend off and not provide the service if I can't. Obviously, I would love to, but by myself, I wouldn't be able to do it. And then every now and then I come back to the UK, see some family, see some friends, and then I do some first opinion work down here. So in Spain, what I have one practice, which is a friendly practice that has my microscope. So if I have to do surgery, that's where I send people to. But the rest of the time, if I can do the surgery in situ, in the practice, then I'll do it there.
You've worked in both referral level and you've worked in GP practice. What would you say that you would wish that GP vets knew how to do a little bit better in terms of regular eye cases that you might see?
So do vets deal with eyes well? I think they do. The problem is a lot of vets, they complain to me in university they didn't teach me enough about eyes, and I panic when they book me eyes come in, and then I know what to do perhaps, but I am worried. I don't like eyes, and I don't like eyes is a little bit like I don't like maths. If you have a poor math teacher, then the rest of your life you don't like maths. Well, maths is fantastic. You just have to have the right teacher. When I was a child, my math teacher was spending 45 minutes joking and 5 minutes teaching. And then I love maths. So with ophthalmology, it's a bit like the same. Now, I find that there are a lot of things that they can be done better. That's one of the reasons. Now, it doesn't feel very forced, but I'm going to advertise a bit. So I do have a Facebook group called Spots. S for sugar, P for Papa, O for Oscar, and D for Delta, and S for sugar again. So it's facebook.com/groups/spots. So pretty much what I do is I put small videos and short videos, short clips. I write things to help people think more than do. How should you do a shimmer tear test? It looks like quite simple, just to look at shimmer tear test, but I see sometimes people who forget to do them or don't know how exactly to do them. You put it in. You're supposed to put it in the lateral third of the lower eyelid
Oh my
and
gosh.
leave
I
it there
often
for a
do the
minute.
upper.
Now, do you know which number are you looking for with the CMRTR test?
You want 15 and over, right?
Yeah, you want 15 and over, correct. But the CMRTR test doesn't just tell you that. It tells you a lot more. It can tell you whether you have some tearing, so sometimes you have more, and you have a lot more in one eye. If you have an ulcer and you have like 22, then maybe that's normal. But what happens if you have an ulcer and you have 15? Yeah, but you should expect more, don't you?
Yeah.
So that is what you're thinking, okay, do we have a patient that, yes, it has an ulcer? Maybe the dry eye is not because of the ulcer, but we know that maybe lubrication in the eye is not that great. You know, things like that. Do you do both eyes when you do a symmetry test?
Yeah,
Most of the time.
Every now and then, yeah.
Yes, do both. And you'll notice as well that often the other eye has a lower reading. And the other eye has a lower reading, not because it's got a dry eye, it's simply a response. It's a pain response from the other eye. And it doesn't mean, so don't underdiagnose dry eye, because very often I see people that, because, you know, they are unsure how to deal with things, that they have an eye that they've been treating with antibiotics for 3 weeks. They gone from vet to another vet and they've been changing antibiotics, when actually bacterial conjunctivitis in dogs is very rare. What they actually seeing is a dog with dry eye, and they've been 3 weeks treating it, and nobody done a Schimmer-Tear test. Then you do it, and then you have 2 jobs. One of the jobs is, you have 3 jobs. One of the jobs is to tell the vet, maybe try this. The second job is to tell the owner without causing trouble to the vet, telling the owner that maybe he spent £150 already in something that could be done in the first appointment. So, you know, sometimes you have to walk a tightrope, you call it, like, it's difficult. I said 3 things. I don't remember the other one. You have to treat the patient, don't you?
Yeah. Do you know, when you're saying that, though, you really got me thinking, because can you sometimes get a falsely dry eye if it's a conjunctivitis? Like you said it's rare, you see, so maybe a bacterial conjunctivitis, but maybe you've got some kind of yellow ocular discharge, you do a Schirmer-Tear test and it's low. Could it be falsely low, and then you do some lubrication and or some naughty antibiotics and then retest in a week? Is that a thing or not really?
It depends. When you have, one of the things we do with Schimmer-Tear test is when you do it pretty much before you do a lot more. Anything that can cause the eye to tear, then you may want to avoid it. So when I see a patient, if I have the time, I understand that, you know, in referral practice, I used to have 1 hour to see my patient. In first opinion, I have 15 minutes, not always. So when the patient comes in, I already see behavior, I'm looking at that. And I do look at eyes more than anything, but because it's what I do. But I think we all do that. We talking to the client, but we actually looking at the pet. We having a chat. We say, "How are you?" But you're actually not paying attention to the conversation. You're actually having a look at the pet. So in the same way, I can see, is it bumping into things? Is it the eye looks a bit red? Is it? And then the next thing that I do is I get a bit history. And I see whether the dog eyes, they do a bit of a menace response, you know, with the dog, because you want to know whether the pet sees or not. But pretty much the next thing I'm going to do is going to be the Schimmer-Tear test. I combine this with neuro-ophthalmology, which is your tassel and your PLR and that. But to do that, you're going to have to put some lights on the eye. You're going to make the eye tear a little bit. So I tend to do the Schimmer test before that. It may not make a big difference, but I try to follow a step by step, you know. And then reasons for dry eye, there are many. The most common that we know is immunomediated. You see, like, you know, these small breeds, usually with lowish tear production. And remember, it's the aqueous. It's not, you know, the tear has 2 layers, and you're actually looking at the aqueous. And that's the reason sometimes it looks like an infection, because you see the tear has a mucin and it have that lipid layer as well, produced by the meibomian glands. So if you are losing the aqueous, what you are left with is with a bit of a thickened mucopurulent-like thing that many people confuse with infection, right? And usually bilateral, but you could have dry eye for several things. you could have a dry eye caused by toxicity, for instance. Did you know paracetamol can cause dry eye?
No, I didn't
It's
know
not
that.
that common. We put a lot of pets on paracetamol, a lot of dogs, but it can cause it. If you
Is
have
that it causes a permanent dry eye or a
usually,
transient?
yeah, usually I
Wow.
haven't seen it done often, but when I seen it, I
Yeah.
haven't seen them recover it. And when you find a similarity test of 0 with only unilateral, they usually this pet presents with an ulcer as well, and then they have that side of the nose dry. Then you have a neurogenic dry eye. You
Yeah.
have completely different treatment. And then we think there are other things. There are a few causes for dry eye, and then you also have the treatment, the common treatment that we use with cyclosporin. It doesn't work at the beginning. You have to keep going for a couple of months sometimes to while you actually helping putting some the artificial tears to help out. So some people, they give it 3 weeks and they say, well, this is not working, I'm gonna stop because this tube is so expensive.
Yeah.
Counseling the owner is important as well. And we just talking dry eye. And most people that I meet, the only thing they understand from dry eye, or they actually tell me they understand from dry eye, yeah, some dogs have dry eye. The shimmer test is low. I'm just gonna put it in cyclosporin. That's not the end of it. There is a lot more. See,
Yeah.
there are patients who don't they don't respond, that you have to use alternative medication. There is a lot. So ophthalmology is actually very cool, but if you don't know, then you'll be scared of it. It's a bit like me being scared of orthopedics.
Yeah.
Yeah. And yet,
Even though I
I'm
used to
like
do
that.
cruciate ligaments and that, but that's
Wow.
because I'm old.
yeah.
I wanted to ask, every practice I go to for a simple corneal ulcer, we
Yes.
have Remend on the shelf. The
Yeah.
Remend for the ulcer. Is that the best product for an ulcer? Or is it just marketing?
Depends what is causing your ulcer, right?
Go on. You don't normally
So
know, do you? Go
what
on.
can cause an ulcer? I mean, one of the things we have, having a product with hyaluronic acid is a good thing. It's proven that hyaluronic acid have a lot of time of recency on the corneal surface. So as an artificial tear is a good thing. It helps. I would use it. Now, how often do we need to use it, and do you really need to use it? You have an eye that is already properly lubricated. Do you really need to use it that much? First thing that people do with an ulcer is put an antibiotic. Correct. I'm not going to stop that. Even though there is a paper, I think from last year, which says that non-infected ulcers don't need antibiotics. Okay.
Yeah.
I'm not there yet. At the moment, I'm too scared. If I see a patient every day, maybe I would risk that. But an ulcer can get complicated very, very quickly. So, my opinion right now in 2026 is I'm using an antibiotic. Okay. Now, which antibiotic you using? So take a sample. Do you take a sample from the cornea? Do you know how to take a sample from the cornea?
No.
It can be done
I
in
don't
first
think anyone
opinion.
takes a sample.
Really?
Most
Dead
people
easy.
don't, do they?
Okay,
No.
so visit my group in Facebook, and there is a free short clip of how to do that. And then you know which antibiotic to use. It's that
Do you
simple.
have a preference of like ointment over watery drops?
Yes, I prefer ointments most of the time because they stay there for longer. So
Okay.
let's say we're going to use chloramphenicol that I don't have in Spain at the moment.
No way.
We don't have it's difficult to get and justify also antibiotic use in Spain anyway. But if you use chloramphenicol eye drops, you'll use it 4 times a day. If you use ointment, you'll use it 3 times a day. Now, one thing is, again, counseling to the owners. I tell owners, don't put the eye drop or the ointment on the cornea. Try to put it on the pocket, on the conjunctiva. Just make the eye blink because the cornea has a lot of nerve endings. The dog or the cat hates it. So try to make sure your patient don't hate it, because if your patient don't hate it, you're not going to have very good compliance. Now, ointment lasts longer, so I would prefer it. However, if you have a risk of perforation, potentially an ointment is not the best thing to use. That's when you're thinking, well, in that case, I'm going to use drops. Okay. But then it's also depending of the dexterity of the pet owner. Some of them find drops easier. Some of them not. Some of them prefer ointment. So, and that is a case of on infection. But most causes that I see in eye ulcer are not caused by infection. They are infected, and then the infection is one of the reasons the ulcer is not healing, but they are not being caused by infection in the first place. They have been caused by other things like exposure. Some pets actually sleep with their eyes open. Then the tear evaporates, and then you have an erosion on the axial cornea in the center. And then, that's when the ulcer starts. Often this happens to brachycephalics, That's one of the causes of ulcers. But there are others. A young dog could have an ectopic cilia underneath the upper eyelid. That's another thing. I'm going to branch into things. Ectopic cilia, distichia, and trichiasis are not the same thing.
Yeah.
Each one starts from one different place. That's very important because knowing which one's which, then it can tell you what is likely to be causing a problem or not, or what you're seeing is just an accident. It's not really true. It's just there and making you think, oh, this is causing the problem. For example, a distichia comes from the edge of the eyelid, from the orifice of the meibomian gland. If a dog is 8 years old, and he have an ulcer, and he have a distichia at the same time, it's very unlikely that distichia is causing the ulcer. Why? Because the distichia has been there for 8 years. Why is it causing an ulcer now? If a young dog has an ectopic cilia, those are the one underneath the upper eyelid, then they could have very painful, usually of a vertical shape, and they can be very painful. So those things come to knowledge, but that knowledge has to come from studying. And if studying that knowledge is painful and boring, then you say, I don't like eyes.
Is it easy for you to run through? Because distichia and ectopic cilia always scare me a little bit. So I feel like I could miss them but is there certain breeds that you go, you're already breeds and age that makes you go, wow, that's likely?
Yes, there are. And I don't remember breeds ever. I do see some distichias in Labradors and that, but I don't tend to remember them. But pretty much breeds with trichiasis. Trichiasis is hairs from the skin, from the actual skin. So trichiasis, when those hairs come from the normal skin. So most of the time, trichiasis come from entropium. When you have a distichia, yes, it's from the meibomian gland. You put your ophthalmoscope. If you don't have a slit lamp, you put ophthalmoscope at 20, and then look through the orifice, and then you go through all the eyelid, all the length, and see each one of the. You can't even count them with that. It'll be 20 or 22 on each side, and see where there are hairs coming from there. Those would be distichias. And then the inside these are more difficult to find because sometimes are very, very small, are the ectopic cilia. I said to you, put your ophthalmoscope at 20. Do you know what that 20 means?
It's the 20 when you turn it, isn't it?
Yeah.
But I don't know what it means.
What's that 20?
No.
What does 20 about?
I just wiggle it around until I see what I want to see.
Yeah, until you see what you
really
want, right?
bad. Yeah.
Okay.
Aren't you supposed to be able to start at 0 and work your way through, and it pans through the eye?
Yeah.
I never remember which way it goes. But
do you know what the 15, 20, 10, what does it mean?
No
It's
idea.
Very easy and very fun.
Go on.
Pretty much is 1 divided by 20. Is 1 meter divided by 20 is 5 centimeters, right?
Right.
So the 20 is
20
telling
centimeters.
you. No.
Oh, yes, 5 centimeters. I got it.
1 divided by 20
Sorry.
is equal 5.
Yes.
1 meter is 100 centimeters divided by 20 centimeters would be 5. So the 20 is telling you that you're going to have the focus of 5 centimeters from your from the thing. So it was 15. It'll be 100 or 1 meter, 100 centimeters divided by 15, and that number is the number of centimeters where you have the focus from your ophthalmoscope.
So as the numbers go down, your focal point is further away from your ophthalmoscope.
Away from you, yes. And the 0 is when you look at the fundus, right? And 1 divided by 0 is infinite. So there is no bending of the light. So if you actually look through your ophthalmoscope, through your room, nothing would have changed. Nothing would change because it's not bending the light. Yeah.
I feel like if we'd have learned this at uni, eyes would make much more sense.
Yeah,
because I feel like they just go, hold
they
this up, put your eye on it and have a look.
Yeah, and they tell you a number. For this one is this number.
Yeah.
But the other thing they do is they turn all the lights down and make you look at slides, and then you fall asleep. Oh, it's really bad to admit that. But do you know
what's very funny? When I start my my consultation of ophthalmology, I start with the lights on. But then at a certain point, after I talk to the owner, it's some history, do a little bit of neuroophthalmology and your shimmer test. Then I actually switch the lights off to actually properly test the LPLR and actually look with the slit lamp or with the ophthalmoscope. When I make the room dark, people stop talking and they start like murmuring, like talking very low, like we went to wait. Yeah, whispering, exactly. That's the word.
Yeah.
Like whispering. I'm thinking, we all here. Nobody's going to sleep. We don't need to whisper. But for some reason in our brain, we're thinking that like whisper.
Yeah.
Okay. Yeah.
Yeah. True.
Anyway, so all those things, you can find them in my group. And then what I do is every couple of months or whatever, when I have the time to do it, then I sell because it's a paid for CPD because it takes me forever to do it. So, and I do is an online interactive session. Okay. And then in that interactive session is usually a small amount of people, like 10, 12 people maximum, never more. So everyone has the opportunity to chat. And then I go through a case. I don't give the answer. I just go through it and I keep asking questions through it. The people can chat, can talk. Some people are happy to chat. Some people don't want to chat. They just write on the chat anonymously. I allow people to be themselves. Something that I have found that made my learning more difficult is that I was afraid of asking a stupid question. It's always been a thing to me. I am not afraid of asking stupid questions anymore. And I don't think you should be, because that just delay your learning. So if someone ask me a stupid question, I'm not gonna take it as stupid. I'm gonna take it as, you want to know, I'm gonna tell you. Humbly, I am still learning.
We love chatting to Francisco. He was so much fun and a really interesting person to chat to. So we hope you enjoyed the conversation as much as we did.
Yeah, he's got that really cool community as well, remember, on Facebook that he mentioned too. So check out the link on our show notes if you're interested in looking at SPODs, his Facebook page discussing all things opt-out and talking through cases, having small CPD sessions, etc. So check it out if you're interested.
Okay, so yeah, time to round up. We've covered loads today, from neutering debates to euthanasia, payment discussions, and ophthalmology in general practice.
Yeah, we hope as ever you've enjoyed listening, and remember to get in touch if you have any comments or suggestions to help us improve these pods for you, any topics you particularly want to cover. And remember, you've got the blog, you've got our WhatsApp number, and you've got socials to contact us through now. So there's no excuse. Please get in touch.
And I know as soon as you hear Charlotte saying that, about 50% of you are just dropping off and pressing the stop button now. But anyway, I'll say yes, absolutely. But for now, thank you for listening. Join us again next Sunday for our extra bonus episode of the month, where we're going to be talking about all things regenerative medicine with our extra special guest. We can't wait.
Yeah, we honestly can't wait. It's going to be such a good one. So we hope you're looking forward to it just as much as we are. So keep an eye out on our socials in the meantime for updates. But until then, it's bye from me.
And bye from me. Take care. This podcast is intended for licensed veterinary professionals and is provided for educational and discussion purposes only. Whilst it's publicly accessible, it is not intended as advice for pet owners.
The views shared are based on our own clinical experience and interpretation and do not replace individual clinical judgment. We accept no responsibility for decisions made based on this content, and all cases should be assessed on an individual basis.
Any references to medications, treatments, or products are made for educational discussion only and are not intended to promote or advertise veterinary medicines to the general public. Veterinary medicine should only be used under the direction of a prescribing veterinary surgeon and in accordance with UK veterinary medicine regulations.
This podcast may include paid partnerships or sponsorships. These do not influence our clinical opinions, and any sponsored content will be clearly identified.